So let's move on to the next question. So we have a 26-year-old woman is evaluated for muscle weakness developing over the past several months. She has no focal symptoms and states that she otherwise feels well. Medical history is unremarkable and there is no pertinent family history. She takes no meds. On exam, BP is on the lower side, heart rate of 98, respiratory rate of 16, and BMI is 19. There is no lower extremity edema, and the remainder of the examination is unremarkable. All right, so they gave us some serum electrolytes, they gave us some urine electrolytes, and I gotta tell you, on your boards, if they give you some urine electrolytes, you know they gotta be important, because all of us, we love the serum. But the minute we start talking about urine stuff, I don't know, normal values get a little iffy, and everyone gets a little kind of panicky, but let's see what the question is. So in this case, sodium looks great, potassium on the lower side. And that kind of relates to, in this patient, muscle weakness, hypokalemia. Chloride a little bit elevated, but look at that bicarb. That bicarb is definitely what? Low. So just looking at the serum electrolytes, patient per se probably has a metabolic. That's right, acidosis. And, and I know, anytime you have a metabolic acidosis, what is the next best thing to calculate to categorize your differential diagnosis? Yeah, you got it. The anion gap. And you definitely have enough to calculate the gap. So does this patient have a anion gap metabolic acidosis? 142 minus 120 minus 15. The answer is no, not even close. So there's a non-gap metabolic acidosis, and there's some urine electrolytes. We got some sodium, potassium chloride, the urine pH, and they did a dipstick, and for what it's worth, there was no protein that was noted there and no blood. So what is the question? Which of the following is the most likely cause of this patient's acid base and electrolyte abnormalities? So once again, what did this patient have, everyone? Yeah, a non-gap metabolic acidosis. And there are a lot of choices over here. So let's kind of go through these and kind of pick it together. So is bulimia nervosa going to be the right answer, everyone? I would say no, based on the nervosa part. What does nervosa mean clinically? Patients are probably doing a lot of what? Yeah, vomiting. And it's a horrible disease. I wish it on no one. But if you're doing a lot of vomiting, everyone, what type of acid-base abnormality do you think you might get? Yeah, I agree. You're probably getting metabolic alkalosis. So that bicarb is going to be a lot on the higher side. So I wouldn't pick that. What is this? Gittleman syndrome? Yeah, I went there. I'm sorry. So there's Bartter syndrome and Gittleman syndrome. Oh boy. And if you have some of these syndromes, they're rare, but what type of acid-base abnormality would you probably get, And I believe a Gittleman syndrome is like being on lots and lots of what? Thiazide diuretics. So if you're on lots of diuresis, you're diuresing all the time, you'll probably develop a metabolic alkalosis, I agree. So it doesn't really fit there. You know what I mean? Laxative abuse, that's going to be a lot of diarrhea. I could buy that. That'll give you a metabolic acidosis. Using a lot of diuretics. That sounds very similar to one of these Barter's or Gittleman syndrome. So if that occurs, you'll probably develop a metabolic alkalosis. And RTA, renal tubular acidosis, well, sure, you'll definitely have a non-gap metabolic acidosis then. So it really comes down to if I'm in a hurry, and this is the question on the boards, is it going to be C or E? So, hey everyone, how are you going to decide what's going to be the right answer for the critical care boards? Well, you know what we didn't really look at too much is the urine electrolytes. And when you have a non-gap metabolic acidosis, why did I put this question here? Is because on the boards, the test writers know you folks are amazing when it comes to anion gap metabolic acidosis. Everyone has some kind of acronym, some kind of mud piles out there that they use to say methanol and ethanol and DKA and lactic acidosis. So, I think that's going to be they will ask you one, but they really want to squeeze in one of those non-gaps in there so you can figure out what's the next step. So the next step to figure out what's going to be the broad differential for a non-gap metabolic acidosis is calculating the urine anion gap. So how do you do that? Well, it's going to be the sodium plus the potassium minus the chloride of all things. So if I take the sodium plus the potassium, that looks like it's going to be 26 minus the chloride, which is 32. Well, I'm really not going to hyper-focus on the number. I really just want to know if the urine anion gap is going to be one of two things. Is it either going to be positive or is it going to be negative? And so if it's going to be negative, well, it pretty much tells me that the kidneys are working well and they're doing its job. So the problem is probably going to be some kind of GI source. Well, if the urine anion gap is going to be positive, it kind of tells me the kidneys are just not doing its job. Maybe they're a little damaged. So it's probably going to be a kidney problem. What kidney problem jumps to mind? It's probably going to be some of these RTAs. So when we talk about this urine anion gap, it's negative. So by default, the answer here is going to be what? C. But why did I put this here? I think many of you got this correct. I really wanted to talk about, hey, why are we talking about the urine anion gap, or when are we talking about this chloride? So remember, when we talk about metabolic acidosis, of course, we want to actually, compensation is going to occur. Of course, our lungs are definitely going to do a respiratory alkalosis, but the kidneys itself want to correct it. And how can the kidneys correct the metabolic acidosis? Well, they can do it in two ways. Number one, the proximal tubule. That's where we do a lot of reabsorption. And trust me, what are you going to want to reabsorb in the prox tubule? Bicarb, because you have a metabolic what? Acidosis. But another way to help balance things out is going to be in the distal tubule. And when we talk about the distal tubule and what is the kidney going to do is they're probably going to be dumping out hydrogen ion. And when we talk about dumping out hydrogen ion in the distal tubule, well, there are two ways we could dump out hydrogen ion. We could do it through what we call these titratable and non-titratable acids. And the most common is going to be these non-titratable. The most common of these non-titratable acids is ammonia. So ammonia is NH3. It combined with hydrogen ion to make ammonium, which is NH4. And that ammonium gets dumped where? In the urine, if the kidneys are doing their job. Now, let me ask you this, everyone. Who has actually ordered a urine ammonium level? The answer is, I haven't. I don't know if you have, but it's just not very common. So we can't really use urine ammonium to figure out the etiology of this non-gap metabolic acidosis. So instead we use urine chloride. So why urine chloride is because urine ammonium, NH4, has a positive charge to it. So something needs to bind to it when it gets dumped in the urine. So urine chloride is part of those urine electrolytes, so very commonly ordered. So it's kind of a surrogate marker for urine ammonium. So let's play the game. Someone comes in and they have lots and lots and lots of diarrhea. They have a non-gap metabolic acidosis. What is the kidney going to do if they're functioning properly? They're going to start dumping out, ammonium, and therefore chloride will be bound to the ammonium. You're going to have a lot of chloride in the urine. So when you do the formula for the urine anion gap, urine sodium plus the urine potassium minus a huge urine chloride, the urine anion gap is going to be what? Negative. So it means that the GI tract is probably the etiology. And of course, we always could say when the urine anion gap is negative, always think about GI tract diarrhea. And of course, on the other side of things, if the urine anion gap is positive, well, you think about RTAs. And of course, RTAs are always going to be such a headache because how many RTAs are there? There's 3. The first one is what? Type 1, which is distal, which makes no sense. Type 2 is what? Proximal. There's no type 3. Then there's type 4, which has nothing to do with the tubule. It deals with the hormone. Which hormone is that? Aldosterone. So it does get a little confusing there, but I think it's important to know what's the role of the urine anion gap in these cases. So I put the formula here just one more time, and we went through all the reasoning why we use the urine chloride as a surrogate marker for urine ammonium. So we have a 23-year-old woman is evaluated in the ED for generalized weakness and lightheadedness for 4 hours duration. She had no previous contact with the healthcare system and takes no meds. On exam, her blood pressure is 120/80 supine, sitting at 105/70. So maybe a little orthostatic. Heart rate is 95 supine, increases to 108 upon standing. BMI is 26. Skin turgor is poor, and there are multiple dental caries are present. There is no JVD. Cardiac exam reveals a regular rhythm with no murmurs. Lung exam is clear. Bowel sounds are hyperactive, and the abdomen is soft, non-tender, and non-distended. I'm not worried about the serum electrolytes here. I'm worried about what? More urine electrolytes. So where's the answer going to be? Probably in the urine. So let's look at the serum electrolytes. We have a normal sodium. Boy, that potassium is low. Chloride is normal. And look at the bicarb. The last question, the patient had a low bicarb. That was a metabolic acidosis. So now we have an elevated bicarb. So you know what I wanted to do for everyone? I want to talk about the complete opposite, which is a metabolic alkalosis. Then we have a bunch of urine electrolytes here. We have a sodium. I put that on the higher side. Potassium is high. And the chloride is low when the urine pH is 7.0. So gave the values of whether they're high or low when we talk about the urine electrolytes. So with that being said, what is the question? Which of the following is the most likely cause of this patient's hypokalemia? All right. So we got some choices here. Let's kind of go through these together. Bartter syndrome. I know our last one was Gittleman's. So Bartter syndrome is kind of like being on continuous loop diuretic. And if you're on continuous loop diuretic, well, trust me, you're going to get a metabolic, alkalosis. So not a bad, answer here. And I think Bartter syndrome works on the loop, just like Lasix, the ascending thick limb of the loop of Henle. And I remember that Lasix furosemide works on what? The sodium, potassium, chloride pump. So you will be dumping out lots of potassium. So I don't know, maybe. Could it be diarrhea? Well, not really. If you're having lots of diarrhea, you have a metabolic acidosis. So that really wouldn't fit with the bicarb being 36. RTA, once again, you know what I mean? It's a acidosis in choice C. This patient's alkalemic. Or vomiting, So if you're having a lot of vomiting, sure, you definitely can develop a metabolic alkalosis. But which one of these is going to be the correct answer? So I look at here, and you know what? It's going to be the deal breaker. It's going to be the what? Yeah, it's going to be the urine electrolytes. And when someone comes in and they have a metabolic alkalosis, there are two urine electrolytes that really help you decide what the right answer is clinically and on board exams. And that's going to be the urine sodium and the urine chloride, urine sodium and the urine chloride. So when we talk about, a patient like this, well, it looks like the urine sodium is going to be high, and it looks like the urine chloride is going to be low. So which one of these is going to fit that? Is it going to be the Bartter syndrome? Or is it going to be someone who's having lots of vomiting? So, I really wish we could just yell out what the right answer is going to be. So if someone's going to be vomiting, what do you think the urine sodium is going to be? And I already kind of predicted. I think many of you are typing in and screaming and yelling, urine sodium is going to be low because the patient's dehydrated and they need to retain that sodium. And don't get me wrong. I definitely hear you out there, but in acute vomiting, especially within the first, 1 to 2 days, urine sodium is actually going to be on the higher side. Go figure. And we'll talk about that in 1 second. And the urine chloride is going to be low, but we already said if you have a Bartter syndrome, you're dumping chloride all the time because what's the pump that's going to be damaging? The sodium potassium chloride pump. So by default, the answer has to be what? Vomiting. Then you look at multiple dental caries and all these things put in there. So it really does fit that clinically. So why did I put this question here is because on your board exams, critical care boards, what are they going to try to sneak in? Number one, a non-gap metabolic acidosis. Number two, a metabolic alkalosis. So I really wanted to spend some time on how do you work up a metabolic alkalosis for the board exams. So when we talk about a metabolic alkalosis, a couple of things jump to mind. Well, I want to organize my thought process and put them into categories. So I really look at three things. I know it says two. One is going to be blood pressure. Two says extracellular volume status. But remember, our extracellular volume is going to include two things. Number one is the intravascular volume. And the other one is going to be the volume in the third space. So third space and intravascular together make up extracellular. So I'm really looking at three things here. So when we do the workup for metabolic alkalosis, I look at these three things and I put them into three categories. Number one is going to be individuals that have a low intravascular volume. So inside the vessel, it's kind of low. But when you do a physical exam, they have increased volume in the third space. So they could be edematous, lower extremity edema. So anytime you have edema, fluid in the third space, well, the main problem is it's got to be a hydrostatic problem or an oncotic problem. And really three organs jump to mind when I think about this. Could be the heart, like CHF. Could they be a cirrhotic or nephrotic? That's how you get volume in the third space, through hydrostatic and oncotic problems. And when you look at these patients' blood pressure, it tends to be on the normal to lower side. So when I think about that constellation of findings, what really jumps to mind? Well, I mentioned it to you already. Heart, liver, and the kidney, nephrotic, cirrhotic, CHF. And when we talk about, why would someone with really, really bad, and let's use the most common thing on your boards, CHF, get a metabolic alkalosis, you can imagine, depending on how bad that left ventricle is, how bad that cardiac output is, how low that EF is, that, all that fluid's going to be where? In the third space. They're going to be intravascularly what? Deplete. They're almost, as if they're like, dehydrated. So what's going to happen is that when, because they're so contracted, is that they're going to rev up because of the decreased volume going to the kidney. They're going to activate an enzyme called renin that activates angiotensin 1 to angiotensin 2 that eventually activates what? Aldosterone. And when we talk about aldosterone, what does aldosterone do? Sure, it can bring back some sodium, don't get me wrong, but it really dumps out two things. What two things can you dump out? Number one, potassium. Number two, hydrogen ion. When you start dumping out hydrogen ion, you develop a what? Metabolic alkalosis. And really, when do we notice this, everyone? Someone comes in on the boards, they have CHF. And of course, what do you want to do? Reduce the preload. How do you reduce the preload? You give them what? Loop diuretics. And remember, all their volumes were to begin with, third space. So now when you give loop diuretic, as you should, you're really contracting the vessel. You're really revving up that renin angiotensin system. And really the next day when you check the serum bicarb, it may go from a bicarb of 24 up to 31 because you develop that contraction alkalosis. So if you want to confirm this, you can check a urine sodium, urine chloride. And remember, not when you're actively giving Lasix, but what's going to happen in the aftermath is that it's almost like they're just dehydrated. So urine sodium is going to be low because the body wants to retain that sodium. And remember, sodium can't come back to the body by itself. It wants to come back neutral. Who does it bring back? Chloride. So low urine sodium, low urine chloride. Now, the second category is intravascular volume is going to be low. There's a normal third space, so no problem with hydrostatic or oncotic pressures, but the blood pressure is on the normal to the lower side. So what really jumps to mind here are two types of clinical categories. Number one, that it could be someone who's what? Vomiting. That was this question over here. Or it could be someone who has one of these rare syndromes, that Bartter or Gittleman syndrome. And that's why I put this question here. This is a classic question you will get in your board exams because it's a little tricky to figure out what is the cause and what is the etiology. So when we talk about someone who's vomiting, what are we going to check? Urine sodium and urine chloride. So why was the urine sodium going to be on the higher side when we talk about vomiting? That's what everyone wants me to talk about. And the answer is that because you're vomiting and you have a metabolic what? alkalosis, that's where we start up here, that the most important thing is your body, your kidney wants to address the metabolic alkalosis. It wants to bring the pH what? Down. How does it do that? Well, there's a very, very special pump in the proximal tubule. And what is this pump? It's going to be the sodium hydrogen pump. Sodium hydrogen pump. They're both positive charges, so they can't go the same way. They're going to go in opposite ways. So what happens when you have a metabolic alkalosis? You retain the sodium. So sodium stays in, which makes sense. And you dump out you bring back the hydrogen ion, you bring back the hydrogen ion, and you dump out what? The sodium. The sodium gets dumped out into the tubule. And that positively charged sodium wants to bind, guess with who? Bicarb, because it's negative. And if you have a metabolic alkalosis, do you want to dump out bicarb in the urine? Definitely. And because of that sodium hydrogen pump, and you're retaining the hydrogen ion, and you're dumping out the sodium, the urine sodium is going to be what? High. That's right. And that's where that very high urine sodium comes from. And this happens acutely. We're not talking about chronic vomiting for weeks and weeks. We're talking about the first few days. But remember, why is the urine chloride going to be low? Is that overall, you're definitely volume down. You're volume down. So even though you want to bring back some sodium, you're still dumping a lot of sodium in there. But when you bring back whatever sodium you can, guess who comes back with it? Chloride. So the chloride in the urine is going to be what? Low. And that's where the low urine chloride came from. So this is going to be a classic question on your board exams versus when we talk about these rare things like Barter's and Gittleman's. Number one, that's never a good answer on the board. Number two, that I mentioned that Gittleman's is like being on thiazides. Thiazides work on the sodium chloride pump. So you're dumping out sodium and chloride. They're both going to be high in the urine. Barter's is like being on Lasix. So it's going to have working on the sodium, chloride, and potassium pump. So in the urine, high sodium, high chloride, and high potassium. Good. And last but not least, I'm just going to just to be complete, someone comes in, their intravascular volume is normal, maybe slightly high, normal to high. Third space is totally normal, but what's going to be the big deal breaker is the blood pressure. And you could circle this a bunch of times. They're going to have a super, super duper high blood pressure. And what do they have? Metabolic alkalosis. So if you kind of have this phenotype, what's going to be the differential? Well, from a medicine standpoint, it's going to be someone who has a Conn syndrome. Conn syndrome is not common. And when we talk about Conn syndrome, it's going to be, an adrenal tumor just cranking out lots of aldosterone. And of course, you can check urine sodium and chloride. Why is the urine sodium going to be high? Once again, what does this patient have? Metabolic alkalosis. What is the proximal tubule going to do? It's going to want to retain the what? Hydrogen. Hydrogen is what? Positive. It kicks out the what? Sodium into the tubule. Sodium will be high in the urine. Why is the urine chloride going to be high in this case? Well, what did I just say earlier? Is that because you're secreting lots of aldosterone does what? It makes you dump out hydrogen and potassium in the urine. Both of those have what? Positive charges. So who's going to bind to the positive hydrogen ion and positive potassium? You got it. Chloride. So the urine chloride is also going to be high. So once again, I really spent a lot of time on this because I just know it's high yield for the boards. So I put this here because what was my bottom line point is that quite commonly when we talk about critical care boards, we always say, well, what's their volume status? Are they volume up, volume down? And one of the things that we always look at is urine sodium, right? And urine sodium, for the most part, is a good marker of intravascular volume. The only time urine sodium is not helpful to determine intravascular volume if you have a what? Metabolic alkalosis. And why is it not going to be helpful? Because of that pesky pump. What is that pump again? The sodium hydrogen pump. Because when you have a metabolic alkalosis, what do you want to do initially? Dump out the sodium. So what do we use instead as a surrogate marker for volume status in the setting of a metabolic alkalosis? Urine what? Chloride. And that is the take-home message. So, let's do another one. 50-year-old woman is evaluated in the ED for a 1-day history of, hearing voices. History is significant for bipolar. And, okay, she's on lithium and she's on quetiapine. That's going to be Seroquel. I don't know about your ICU, but my God, my fellows love handing out Seroquel like it's candy in the ICU. Check that QT interval. On exam, the patient is disheveled and looks chronically ill. She's alert and oriented, but appears anxious. All right. Blood pressure is 138/78. Heart rate is 80 without orthostatic changes. There is no edema. The remainder of the exam is normal. And they give some lab studies. Don't worry, everything is where? In the serum, so it's good. Oh, there's a little urine there. I take it back. I'm sorry. There's some urine in there. So BUN looks all right. Creatinine looks good. But look at that sodium, 126. It's low. Potassium's okay. So is the chloride. So is the bicarb. And glucose is okay too. And it looks like the urine sodium in this case is going to be, well, for time's sake, I'm going to help you out a little bit. It looks to be what? High or low? It looks low. Urine osmolarity seems to be what? High or low? Yeah, it seems pretty low. So you got a low urine sodium, a low urine osmolarity, and sodium is 126 in the serum, and she's coming in for hearing these voices, and she has bipolar. All right. And she's on lithium and Seroquel. Okay. Which of the following is the most likely cause of this patient's hyponatremia? Man, I really wish we could interact a little bit. I'm so excited. So, anyone, do we think the answer is hyperglycemia? Probably not, but for one reason, seeing how the glucose is what? Normal. So I'll take that off. What about nephrogenic diabetes insipidus? Does anyone want to pick that one? Probably not, because, if you have nephrogenic, or if you have diabetes insipidus in general, that serum sodium is definitely not going to be what? Low. It's definitely not going to be low. It makes no sense. So it's not going to be B. And why did he put this here? Probably because of that lithium, So it really comes down to psychogenic polydipsia. I don't know when's the last time I answered that on the boards. SAADH, all right, or she volume down. So how are you going to decide what is the right answer here? Yeah. You guys know and gals know me so well now. It's all about the what? The urine. So if you haven't noticed the theme here, I know every one of you are going to get the serum stuff, boom, like that. It's all about the urine. So what was one of the choices? It was SAADH. I don't think she's at risk for SAADH. There's no something in the CNS. There's no lung cancer. There's no pneumonia over there. And if you had SAADH, everyone, what would the urine sodium and urine osmolarity be? Just yell it out. Okay, I can't hear you. But the urine sodium and SAADH should be high. The urine osmolarity and SAADH should be what? High. So, just by default, it can't be this based on the lab studies. Volume depletion. All right. If you're volume down, the urine sodium needs to be what? Low. All right. This could be it. I don't know. Urine sodium is very low. And the last one was someone who has psychogenic polydipsia, like chugging water. So if you're chugging lots of water, what would your urine sodium be? Well, it's going to be very dilute. So the urine sodium has to be what? Low. So it really comes down to, urine sodium is low in both. So how do I pick what is going to be the right answer if urine sodium is low for both polydipsia and being volume down? You got it. What's the thing you have to look at next? It's going to be the urine osmolarity. So urine osmolarity, we don't think about it that often. We sometimes don't realize why it's going to be important. So if you're going to be dehydrated, what would the urine osmolarity be? High. Well, if you have this psychogenic polydipsia or chugging lots of water, it's going to be a very dilute urine. So urine sodium is going to be what? Low. And the urine osmolarity is also going to be low. So the answer is going to be what? polydipsia. All right. So, and for the boards, you know what I mean? Maybe they're not going to make it, hey, someone's just drinking tons of water. Nina, I'm sure I work in the county hospital sometimes, and sometimes we have people that have beer podomania. So I think that'd be a fair question for the board exam. Someone comes in and trust me, they're not drinking the air quote good beer. I think they're drinking, what is that watered down beer that people drink? I forget. It's like what? Keystone, Coors, Pabst Blue Ribbon. I don't know. I'm sure you guys are coming up with some other ones. But if you're drinking lots of beer, it's called beer podomania, very similar to psychogenic polydipsia when you look at the urine. Okay. And I put tea and toast here because many of us have old, patients who starting to get demented. They don't have good caretakers, and it gets to be called tea and toast syndrome, but they'll have more of a normal urine osmolarity in these cases. So let's do one more, and then maybe we could do a little bit of teaching about sodium. How's that sound? Sound good? Okay. So 18-year-old woman is brought to the ER by friends. She is confused. She is febrile, and her friends state that she took some ecstasy at a party, but she was previously well with no past medical history. So stop right there. So why am I bringing ecstasy in here? So and I know on the critical care boards, they love toxicology. They love talking about, whether it be PCP or cocaine or something like that, or toxic alcohol. So definitely ecstasy is fair game for the board exams. All right, so took some ecstasy, comes in confused and febrile. On exam, patient's definitely confused. She's only oriented to her name. She is beyond febrile at 102. Her blood pressure is 148/94. She's tacky, tachypneic at 20, O2 sats 96%, and she's on 2 liters of nasal cannula. The remainder of the exam is unremarkable. And of course, we're going to get some labs, and it looks like her BU and creatinine are okay. Stop right there. Check out that urine sodium. That urine sodium is definitely what? Low, 118. Then potassium chloride, not too bad. Bicarb, starting to edge down on the acidotic side. And to give a urine osmolarity, and contrary to this last urine osmolarity right here, which was low, this one looks pretty what? Yeah, this one looks pretty high. You have a high urine osmolarity. So sodium is 118. She's only 18 years of age. She took ecstasy. Which of the following is the most appropriate initial treatment? So classic critical care question. What do you want to do with this 18-year-old person? So do you want to do a normal saline bolus at 100 mLs per hour? Do you want to give a little hypertonic, 3% saline, give a 100 ml bolus? Should we do some fluid restriction? Do you want to use a Vaptan? These are vasopressin 2 receptor antagonists, got the FDA approval for people with SAADH, or oral urea. And I'm going to tell you something for time's sake, that will be the wrong answer on the board exams. We don't use oral urea to help correct hyponatremia. So the answer here is going to be this patient is symptomatic. It's acute hyponatremia in the symptomatic realm that, sure, it's always nice to know what etiology is, but this question talks about how do you treat her? And when you have symptomatic hyponatremia, acute mental status changes, acute neurological symptoms, you got to give what? Say it. Hypertonic. So the answer here is going to be what? B. But why am I talking about this is because what really dropped this 18-year-old sodium so fast? It's about ecstasy. So when we talk about ecstasy, you can definitely get fatal hyponatremia, which is why it's going to be on your board exams. And how do these patients become hyponatremic? In 2 ways. Number one, when you take ecstasy, it really just makes you super, super thirsty. I think when you watch these movies that people are just drinking a ton over there. So you're taking in lots and lots and lots of fluids, but at the same time, you develop what? This SIADH type syndrome where you have anti-diuretic hormone, inappropriate secretion of antidiuresis. So if you're retaining the fluid and you're drinking fluid, your sodium is really going to what? Drop. And what's scary about this is that this can occur, this drop in sodium, regardless of how much you took. So this is going to be a triple star, high yield pearl for the board exams. So with that being said, what I wanted to do, and I apologize that I went over here, is I'm all about making these little charts to help you get all the right answer on the boards. So just like I did for metabolic alkalosis, here's how I work up hyponatremia, really focusing on the question itself. So once you're hyponatremic, what should you do? You could calculate or order serum osmolarity, right? Calculating serum osmolarity is 2 times the sodium plus the BUN divided by 2.8 plus the glucose divided by 18. Or you can measure it. And why do you sometimes want to calculate and measure it? Well, if you want to calculate the osmolar gap. And you and I know when they're going to ask about osmolar gap, when they give you a toxic alcohol, something like ethylene glycol, something like methanol, always think about that osmolar gap. So once you calculate serum osmolarity, you could bring into 3 main categories: hypoosmolar, iso, and hyperosmolar. So from the hyperosmolar, that seems weird. How can you be hyponatremic but hyperosmolar? Odd. So one of the things that can do that is being hyperglycemic, and of course the other thing could be on medications such as mannitol. So if you're doing neurocritical care, maybe someone comes in with increased intracranial pressure. And of course, mannitol is an osmotic diuretic. It's osmotically active. And if you're giving mannitol and you measure serum osmolarity, it's definitely going to be what? High. You can't calculate it. If you measure it and you're giving mannitol, it's definitely going to be high. And why does hyperglycemia make you hyponatremic? Well, it's all about that fluid, right? Shifting into the vessel, out of the cell into the vessel, really diluting that sodium. Well, over here, if you're isoosmolar, remember everyone that that's kind of weird. How can you be hyponatremic but be isoosmolar, And this one really doesn't make a lot of sense in the year 2022. Why? Is because this is more of a measuring error. That in the olden days, we wanted to measure, serum sodium. If you had high levels of proteins or high levels of lipids, that, remember everyone, proteins and lipids, most of them have what charge? Negative. If you have lots of protein, like in multiple myeloma, Waldenstrom's macroglobulinemia, amyloidosis, you have lots of protein, it's going to kind of bind to that sodium. So when you measure it, it's going to be falsely low. Same thing with lipids. Remember, they're called lipoproteins. They kind of have a negative charge. Same concept right there. So, when we talk about hyperosmolar and isoosmolar or hyponatremia, that it's really, those two together are kind of like pseudo-hyponatremia. Really, if you're going to be hyponatremic by definition, you got to be what? Hypoosmolar. Let's look at that serum osmolarity. It's 2 times the sodium. So if you're truly hyponatremic, you got to be hypoosmolar. And once we know you're in this category, how do I work up the question in my mind at least? I look at 2 things. Volume status, which is very what? Subjective, But then to be objective, I love to look at the urine sodium. And in this question, we talked about urine osmolarity. So we're going to do both together. So based on subjective volume status, hypovolemic, hypervolemic, and euvolemic, right? And so hypovolemic, not a good answer on the board exams, because to be hyponatremic, you really got to lose hypertonic fluid, which isn't really, not really clinically relevant. We don't really lose hypertonic fluid, but because you're going to be a loss of volume, because you're going to say this patient's going to be dehydrated, well, you can imagine urine sodium is going to be low. If you're going to be hypervolemic, well, what's going to give you hypervolemia in physical examination? Problem with oncotic pressure or hydrostatic pressure. So who's going to be the main culprits? The heart, the liver, and the kidney. Most common question is what? CHF on your boards. Trust me. And if you have really bad CHF, everyone, is being hyponatremic a bad prognostic indicator for heart failure? The answer is what? Yes. They'll love to throw that in the critical care boards. And of course, why do these patients with CHF become hyponatremic? Well, it's all because of the fact that when they're volume down, when blood is going back to the right atrium, there are literally things called stretch receptors in the right atrium. And what happens is these stretch receptors actually will sense you being volume down. They'll influence the secretion of ADH, antidiuretic hormone. So ADH is strongly influenced by what? serum osmolarity, but also influenced by volume status. And trust me, people with CHF do not need more ADH. So you get that secretion of antidiuretic hormone. What happens to sodium? It dilutes. So your heart has to be pretty bad for you to cause your body to secrete ADH based on volume status. So what happens in these cases when you check urine sodium? Because in the vessel, your volume what? Down, urine sodium is going to be low. Euvolemic, there's a very broad differential diagnosis here. And I don't have the time to go through each one, but and I know what's going to be the question on your boards. It's going to be SIADH, right? We already talked about psychogenic polydipsia. We talked about people who come in and ecstasy, which is going to be one of the things I think about on the boards, but SIADH. And if you're going to have SIADH, we already said urine sodium is going to be high. Urine osmolarity is going to be high. Of course, treat the underlying cause. Of course, think about fluid restriction. Of course, in some cases, you can think about tolvaptan and conivaptan. And urine sodium, as I mentioned, is going to be higher in this place. When is urine osmolarity going to be a deal breaker? It helps determine who has someone who has volume down, being dehydrated with a low urine sodium, versus someone who has psychogenic polydipsia or hyponatremia, where urine sodium is going to be low also, but urine osmolarity is going to be the deal breaker. Low in hyponatremia and polydipsia, high when you're going to be dehydrated.